Hello guys, welcome back. Now today in this class, let's begin with the endocrine pathology. Okay, let's begin with the endocrine pathology, sir. Now in the last class, we have completed the renal pathology. Okay, all the renal tumors, nephritic syndromes, nephrotic syndromes, everything is completed. Now in this class, let me do the thyroid. Okay, in the endocrine disorders, the most important endocrine pathologies are going to be thyroid disorders. Definitely questions will be coming from the thyroid. Okay, so first I will try to do as thyroid, and let me see how much I can do in the parathyroid. Why? Because thyroid is a very big chapter. Okay, thyroid is a very big chapter. So I will complete the entire thyroid, and whatever is possible to do in the parathyroid, I will do it. If not, we will continue in the tomorrow's class, the parathyroid things. Okay. Having said that, without any further late, so in this 1.5 hour class, okay, 1.5 hour to 2 hours of class, okay, let me see how much time it will take. What we should know is the thyroid disorders like hyperthyroidism, hypothyroidism. Also, we have to discuss about the thyroid neoplasias, okay, thyroid tumors, different types of thyroid cancers, okay, both benign tumors as well as the malignant ones. So without any further late, let's begin. Okay, so let's begin with the thyroid gland. Look here, thyroid gland. So you know, thyroid gland is having two lobes. The thyroid gland is going to have the two lobes. Now in this thyroid gland, T3, T4 are produced. How the T3, T4 are produced? First you should know the basic thing. Okay, the basic things which you should know is, so here is the hypothalamus. This is the hypothalamus. Now down to the hypothalamus, there is pituitary gland. This is anterior pituitary. Okay, there is anterior pituitary. So there is a hypothalamus, anterior pituitary. From the hypothalamus, who is coming? Thyroid stimulating hormone. TSH is, sorry, not TSH, TRH. Okay, thyroid releasing hormone is getting produced. TRH is getting produced from the hypothalamus. This TRH, it will come and act on the thyrotropes. Now when this TRH, when it is acting on the thyrotropes, now what these thyrotropes are going to produce? They are going to produce a TSH. Now this TSH, it's coming and acting on the thyroid gland. It's acting on which cells? See, in the thyroid gland, there are cells called as the follicular cells. Now whatever I am drawing here, these are the follicular cells. Look, these are the follicular cells. Now this TSH receptors, the TSH receptors are present on the follicular cells. Now the follicular cells are getting activated because of this TSH. TSH is going to stimulate the follicular cells. Now these follicular cells are going to produce T3, T4. Okay, T3 and T4. The major hormone is the T4. The most quantity, the most of the thyroid hormone is in the form of T4, thyroxine, T4, the thyroxine, and the active form, but the active form is T3. Okay, so both T3 and T4 are produced from the follicular cells, right? Now, important point is, so between the follicular cells, okay, there are some parafollicular cells are also present between the follicular cells. Okay, between these follicles, okay, this entire thing, whatever I have shown, the round color, that's called as a follicle, which is made up of the follicular cells. Now, surrounding the follicular cells, there are parafollicular cells. These are the parafollicular cells. So, these parafollicular cells are the ones which are going to produce calcitonin. Okay, so thyroid gland, now from onwards, you should know the thyroid gland is the one which produces thyroid hormone as well as the calcitonin. Now, what is the function of calcitonin? The function of calcitonin is to decrease the blood calcium levels. Okay, decrease the blood calcium levels. Then which hormone increases the blood calcium levels? Parathyroid hormone. Parathyroid hormone increases the blood calcium levels. Calcitonin decreases the blood calcium levels. So you should know that the calcitonin and the parathyroid hormone, they are antagonistic hormones. They are antagonistic hormones because their action, physiological antagonists, their action is different. Okay, so the calcitonin and parathyroid hormone are antagonistic hormones. Now, what they will ask you is, see, this is the thyroid gland. Now, in the thyroid gland, please look here, guys. What are these? All these are the follicles. Okay, all these are the follicles. Okay, so all these are the follicular cells. Okay, these are the follicular cells. These follicular cells, what they are forming? They are forming the thyroid follicles. Now, in the center, see, there is this pink color area, right? This is called as colloid. That's called as a colloid, sir, where T3 and T4 are going to be stored for almost 3 months. Okay, once the T3, T4 are formed, they can be stored for 3 to 4 months, of course, 3 to 4 months. Okay, so these are the follicles. In between the follicles, what do you have? In between the follicles, see, देखो here, What are these? These are the parafollicular cells. Okay, parafollicular cells, also called as T cells. Okay, so in your exam, okay, in the recent NEET PG exam also this question has been asked. They have given this image, okay, and they have asked to identify, what are the cells. See, what are these? These are the colloid, okay, surrounded by the follicular cells. These are the follicular cells forming the follicle. First of all, there is a thyroid follicle. In the center of the follicle, there is a colloid. Okay, there is this thyroid follicle. This is the thyroid follicle. In the center of the follicle, colloid is there. Colloid is the pink color material where T3 and T4 is present. Okay, T3 and T4 is present. Okay, and even thyroglobulin proteins are going to be present. Now, what are these cells? These are the parafollicular cells. Okay, between the follicles, there are parafollicular cells. So, you have clearly seen here the histology, follicular cells as well as the parafollicular cells. Okay, so this is how the thyroid gland histology is going to look like. One thing you should never ever forget. Okay, next, having said that, now let me directly jump into a disease. Okay, let's begin with the pathologies. The first disease that I want you to know here is called as a Graves' disease. Okay, Graves' disease. Very important for your exam. First question, so Graves' disease, is it going to cause hypothyroidism or hyperthyroidism? First thing, remember, it's going to cause hyper. Okay, it's going to cause hyperthyroidism. It's going to cause hyperthyroidism. Okay, sir. What's the problem? What's the problem? Why hyperthyroidism? What exactly is happening? See, you know that thyroid stimulating hormone from the anterior pituitary, TSH, it's going to come and act on the follicular cells. So, follicular cells are the ones which are going to produce T3 and T4. This is normal, right? So, TSH is going to act on the follicular cells. So, the follicular cells produce T3, T4. That's something normal. But what happens in this Graves' disease is, see, it's the autoimmune disorder. First of all, it's the autoimmune. Now, in this condition, Graves' disease, there is production of antibodies, autoimmune antibodies, autoantibodies, which are called as LATs. There is production of autoantibodies called as LATs. Sir, what is LATs? Long acting, thyroid stimulating, okay, long acting thyroid stimulating antibodies. Okay, LATs, L-A-T-S, LATs. LATs are the antibodies. Now, most of the students know that, sir, antibodies are going to cause the destruction of the tissue. Antibodies, they will cause, like, destruction of the tissue. Autoantibodies will cause damage. You know it. But these are special antibodies. See, long acting thyroid stimulating. They are not going to destroy the thyroid gland. They will stimulate the thyroid gland. So, antibodies are produced. So, definitely autoimmune disease. But these antibodies are stimulating the receptor. Which receptor? So, these LATs antibodies, they will stimulate the TSH receptor. Okay, they will stimulate the TSH receptor present on the follicular cells. So, now this TSH receptor is being stimulated. So, when the TSH receptor is getting stimulated, what these follicular cells will do? So, the follicular cells will produce T3, T4, more amount of T3, T4. Okay, unnecessarily more amount of T3, T4 is being produced. So, that's what the problem in the Graves' disease. Okay, that's what the problem in Graves' disease, sir. Okay. Now, in this Graves' disease, if you look at the Graves' patients actually, see, they are going to have their eyes something like this. Okay, like this. Graves ophthalmopathy. Okay, there is proptosis. Now, here itself I am telling you why this proptosis. Okay, see, these antibodies will also stimulate. Okay, these LATs antibodies are also going to stimulate the fibroblasts. Okay, behind the eye. So, these fibroblasts are going to produce more amount of collagen back to the eye, sir, back to the eye. Okay, so the exact reason for proptosis is not known. It is believed that in Graves' disease, that the long-acting thyroid stimulating antibodies, LATs antibodies, stimulate the fibroblasts, so that these fibroblasts are going to produce more amount of collagen back to the eye. So, because of this extra tissue, the eyes will be pushed forward. So, that's the reason for proptosis. And many other things were there, like, there is deposition of glycosaminoglycans, okay, behind the orbit. So, many things are there, but simple. LATs antibodies stimulate the fibroblast. more collagen, pushing the eyes forward. Okay, proptosis is seen. So this is something very important. Proptosis is seen in Graves' disease, not in other thyroid disorders. See, there are other causes of hyperthyroidism. There are other causes of hyperthyroidism. If there is a nodule, okay, if there is a tumor in my thyroid gland, that can even cause hyperthyroidism, but there is no such thing as proptosis. Okay, so proptosis, whenever you are seeing proptosis, they are talking about Graves' disease. Yes, of course, Graves can cause hyperthyroidism, but now what we are discussing, I have explained you that the long-acting thyroid stimulating antibodies stimulate the TSH receptors, so more T3, T4. So it's an example of which type of hypersensitivity reaction? It's an example of, say, first of all, hypersensitive reaction. Okay, it's an example of hypersensitivity reaction. Why hypersensitivity reaction? Because there is some problem with the immune system. Immune system is doing overaction. The antibodies are going unnecessarily and stimulating the TSH receptor, right? So it is an example of hypersensitivity reaction. Which type of hypersensitivity reaction? Type 1, type 2, type 3, type 4? Which type? Let's say type 1 hypersensitivity reactions are going to be because of allergies, because of IgE antibody on the mast cells, asthma, you know it, right? That's type 1. Type 2 are autoimmune diseases. Type 2 are autoimmune diseases where antibodies are produced. These antibodies are going and destroying the tissue. The antibodies are going and destroying the tissue. That is type 2. Here there is no tissue destruction but tissue stimulation. Type 3. The type 3 are because of antigen antibody complexes, immune complexes that are circulating in the blood and they are getting deposited in different tissues and causing the inflammation. These are type 3 hypersensitivity reactions. Type 4 are cell mediated immunity. It is the cells, the T lymphocytes, B lymphocytes, they will infiltrate into the tissue and cause the tissue damage. That's type 4. Type 5, new type of hypersensitivity reaction. So these are example of, see, now antibodies are produced against the receptor and these antibodies are stimulating that receptor. So this Graves is an example of type 5. Okay, type 5 hypersensitivity reaction, not type 1, type 2, type 3, type 4. Some books mention as type 2, older classifications mentions as type 2, but remember the type 5 hypersensitivity reaction. Okay, if you don't find type 5, you can go with the type 2. Okay, then sir, next. So what else I should teach you regarding the Graves' disease? I have explained you everything, like it's autoimmune disease, antibodies stimulate the TSH receptor, the LATS antibodies. It's going to cause the hyperthyroidism because of more stimulation. It's going to cause the hyperthyroidism. Now in Graves' disease, what kind of enlargement is seen? So the thyroid gland is going to enlarge, definitely because of too much stimulation. The thyroid gland size, it's going to enlarge, sir. It's going to enlarge. So, right, there is goiter. In Graves, the patient is going to have goiter. Now, students have a lot of misconception about the goiter. People will think goiter is going to be seen in hyperthyroidism conditions only. No, no. Sir, goiter means just what exactly is goiter? Goiter means enlargement thyroid gland. Enlargement of thyroid gland. Goiter means enlargement of the thyroid gland. The thyroid gland is simply enlarged. Bigger thyroid gland. So goiter can be seen in hyperthyroidism, euthyroidism as well as hypothyroidism. Hypo as well as in normal conditions also, euthyroid conditions also you can have the goiter. Simple goiter means enlargement of the thyroid gland. In Graves' disease, yes, there is goiter, true. But question is, how the thyroid gland is going to enlarge? Diffuse enlargement is going to be seen, or only one lobe enlargement or a particular part enlargement is going to be seen? What do you think? Is there a diffuse enlargement or nodular enlargement? What kind of enlargement do you think? Sir, antibodies, they will attack the entire gland. They will attack the entire TSH receptors. They will stimulate the entire TSH receptors. The entire thyroid gland is going to increase. So there is the diffuse enlargement. Okay, diffuse enlargement of thyroid gland. There is a diffuse enlargement of the thyroid gland. Okay, it's not the nodular enlargement, diffuse enlargement. Okay, so usually you are suspecting, okay, this patient is having goiter. Okay, this patient is having goiter, maybe because of the Graves' disease. Okay. Now, if you perform a study called as REIU, so have you ever heard about this study REIU? So, what exactly is this REIU? REIU means radioactive iodine uptake. Okay, what exactly is it? Radioactive iodine uptake. Okay, means simply I am just mixing the radioactive iodine. I am taking this radioactive iodine. I have taken the radioactive iodine. Sir. Now, if I take this radioactive iodine, look, I have taken the radioactive iodine. Now, tell me which tissue is going to utilize this iodine? Sir, of course, it's a radioactive iodine, but still it's iodine, right? So, where do you think this radioactive iodine is going to be concentrated? Where do you think? So, this radioactive iodine, it will be taken by the thyroid gland. Okay, radioactive iodine will be taken by the thyroid glands uptake. Now, thyroid gland, tell me in Graves' condition, is it working more or less? It's working more because of overstimulation. So, will it take more iodine or less iodine? It will take more iodine, sir. More iodine uptake will be seen. Lots and lots of iodine is going to be concentrated, sequestrated in the thyroid gland. So, now this is not normal iodine, it's a radioactive iodine. So, now this radioactive iodine is concentrated in the thyroid gland. Now, it is going to emit the radiations. Now, it is going to emit the radiations, sir. Now, you are going to pick up this radiation, okay, and you can see the thyroid gland. So, this study is called as radioactive iodine uptake. Now, let me show you the image also. Look here. This is a normal thyroid gland. Okay, this is a normal REIU study. Okay, radioactive iodine uptake study. Where, yeah, thyroid, it's normally functioning. It will take a little amount of iodine, not much amount of iodine. It will take whatever is needed, little amount of iodine. But in a patient who is having diffuse enlargement of thyroid gland, where the gland is super active, see, it is taking lots and lots of iodine, and you can see the gland is emitting more radiation. Okay, that's why when compared to the normal, see how the Graves' disease is looking like. So now you can say, sir, there is a diffuse enlargement of the thyroid gland. Okay, that's MCQ. And what happened to the REIU study? Sir, radioactive iodine study is going to be increased. Okay, increase means more radioactive iodine uptake. Okay, now after this, what else I should teach you? See here itself, let me teach you about the hyperthyroidism. So let me teach you about the hyperthyroidism. One cause of hyperthyroidism is Graves' disease, don't forget, okay? Hyperthyroidism. Okay, hyperthyroidism, sir. Now, one cause, what are the causes? The most common cause of hyperthyroidism is Graves' disease. Okay, the most common cause is Graves' disease. What else, sir? What else can cause hyperthyroidism? See, in the thyroid gland, there is a tumor in thyroid gland. Okay, there is a tumor in thyroid gland. Okay, so Graves' disease is one cause. There is a tumor in the thyroid gland. There is a tumor. That tumor is producing excessive amount of thyroid hormones. Okay, simply like that. For example, see, look here. This is a thyroid gland. Now, there are tumors. Multiple nodules are there. Multinodular goiter. Okay, something like that. Okay, so this is one of the cause. Now, other causes can be, see, this is the normal hypothalamus. Okay, imagine here is the hypothalamus, sir. Here is the pituitary gland. Here is the thyroid gland. Here is the thyroid gland. Now, there is everything normal with the thyroid gland, absolutely normal. Because of some reason, see, imagine there is a tumor in the pituitary gland. There is a tumor in the pituitary gland. Now, what this tumor is doing? Unnecessarily, it is producing more and more TSH. Now, this TSH, lots and lots of TSH is there. So, this TSH is coming and stimulating the gland, thyroid gland. So, thyroid gland, in response to this stimulation, is producing more amount of T3, T4. So, again, hyperthyroidism. At the end of the day, there is hyperthyroidism. So, here what are the causes I am explaining you for the hyperthyroidism? Graves' disease, or tumors in the thyroid gland, or tumor in the pituitary gland. So, based on this, let me tell you how many types of hyperthyroidism are there. there are two types of hyperthyroidism. One is a primary hyperthyroidism and secondary. Primary hyperthyroidism and secondary hyperthyroidism. So what exactly is primary hyperthyroidism? So in primary hyperthyroidism, the problem lies at the level of gland, thyroid gland. Means some problem at the level of thyroid gland. Some problem is there, but with the thyroid gland, there is no problem in the hypothalamus or pituitary. Some problem in the thyroid gland. That is primary cause. Secondary is problem lies at the level of pituitary gland. Pituitary gland. Okay. So, how many types of hyperthyroidism is there? Two types. Actually, there are three types. Some books mention primary, secondary, tertiary. But generally, what you need to know is the primary hyperthyroidism, secondary hyperthyroidism. What exactly is primary hyperthyroidism? Problem lies at the level of thyroid gland. Example is what? Graves' disease. Graves' disease. Okay, in Graves' disease, they go, what is the problem? There is a stimulation of the thyroid gland. So, more T3 and T4 are getting produced. Okay, so example of primary is Graves. Okay, example of primary is Graves. Now, in Graves, let me tell you, if you look at the labs, the T3 levels and T4 levels are elevated, no doubt. No doubt, T3 and T4 are elevated. What about the TSH levels? What about the TSH levels? See, Graves, it is hyperthyroidism, okay, more amount of T3, T4. But once you have good amount of T3, T4, what this T3, T4 will do, especially T4, what it will do? It will give negative feedback. It will give negative feedback. Array, enough amount of T3 and T4 are there. So, no need of further TSH. No need of further TSH. So, what happened to TSH levels? That in this condition, the TSH levels are going to go down. In primary, the TSH levels are decreased. Okay. So, how to differentiate between primary hyperthyroidism and secondary hyperthyroidism? In primary hyperthyroidism, the T3, T4 levels are elevated. But if you look at the TSH levels will be less. TSH levels will be less. Why? Because of negative feedback. Okay. But in secondary, dekho. Sir, secondary, what is the example? Pituitary tumor of pituitary gland. Okay. There is a tumor of pituitary gland. If there is a tumor of pituitary gland, it is producing excessive amount of TSH. So, what happens, sir? In secondary, the important difference is here. In secondary also, if you look at the labs, the T3, T4 levels are elevated, no doubt. But what about the TSH levels? The TSH levels are also more TSH will be there. Okay, in both the conditions, T3, T4 are elevated. In primary or secondary, it doesn't matter. It's a hyperthyroidism, so T3, T4 levels are elevated. But if you look at the TSH levels, the TSH levels will be less in primary, but TSH levels will be more in secondary hyperthyroidism. In primary, there is problem at the level of gland. In secondary, there is problem at the level of pituitary gland. Okay, pituitary gland. So, having said that, I have explained you the two types of hyperthyroidism. Now, let's see the clinical features. Okay, well, let's see the clinical features of hyperthyroidism. Okay, right? Clinical features. So, in 5 minutes, we should know what are all the clinical features that are going to be seen, sir. See, the thyroid hormones are more like sympathomimetic hormones. Okay, they are more like sympathetic hormones. They activate your body. Okay, they activate your body. First, let me write one by one. Thyroid hormones increases your basal metabolic rate. The basal metabolic rate, the number of calories which are required for maintaining the homeostasis in the body. See, for example, to run this body in a simple way, to run this body for the next 24 hours. Okay, to maintain all the chemical reactions in this body, biochemical reactions, to maintain this body under the homeostasis. How many calories are required? As an adult male, I will require somewhere around 3000 to 3500 kilocalories. Okay, that's my basal metabolic rate. But if I am doing more exercise, okay, imagine I am an athlete, my basal metabolic rate is going to be increased. But if there is a hyperthyroidism, imagine there is a male or a female who is suffering with hyperthyroidism. So what happened to their basal metabolic rate? No need to do any activity. Simply their basal metabolic rate increases. Okay. So in hyperthyroidism, the basal metabolic rate increases. Okay. And the question which was asked is, how sir? How basal metabolic rate is increased? See, now imagine this is the active form of thyroid hormone T3. Now this T3 is acting on your tissues. Imagine this is your cell tissue. Now when T3 is acting on the tissues, actually what you should know is this is the question which was recently asked in the exam. Okay, recently asked in the exam, in the Indian FMG exam. So the T3, it will enter into the tissue, sir. Enters into the tissue. There is no cell surface receptor. T3 enters into the tissue and T3 directly goes into the nucleus. So thyroid hormone receptor, T3 receptor is present in the nucleus. So thyroid hormone binds with its receptor and it's going to activate certain genes, transcription, translation is going to occur. At the end of the day, look, because of this T3, on the cell surface, more number of proteins are coming. Sir, what are these proteins? See, there is increase in the number of these blue color proteins. Sir. Do you know what are these proteins? These are sodium, potassium, ATPases. So the number of sodium, potassium, ATPases are going to increase. In the name itself it's there, ATPase means more number of ATP are going to be broken down, more calories are being used by the body. The basal metabolic rate increases. So tell me, thyroid hormone's first function increases the basal metabolic rate. How? By increasing the number of sodium, potassium, ATPases on the cell surface. By increasing the number of sodium, potassium, ATPases, it increases the basal metabolic rate. Right? Now, question which was asked in the exams is, thyroid hormone increases the basal metabolic rate. Okay, in all the tissues except thyroid hormone increases the basal metabolic rate in all the tissues except testis. Okay, except in the testis, uterus, lymph nodes, spleen, anterior pituitary. Okay, so these are exceptions, sir. So these are the tissues where the basal metabolic rate is not increased. Okay, only in these tissues the basal metabolic rate is not increased, but in all the other tissues basal metabolic rate is increased. Means more number of calories are going to be broken down. Now let's come back. Imagine there is this one fellow who is having hyperthyroidism. So his basal metabolic rate will be less, will be more. More number of calories are getting utilized. More ATP is getting broken down. So what happened to his body temperature? Sir, more energy, more calories are being utilized. More ATPs are getting broken down. So what happens to this fellow is where basal metabolic rate is increased, the body temperature increases. The body temperature is going to be more. So if you look at his basal body temperature, he's going to be warm. Okay, he's going to be warm. Okay, so now where he would like to sit? See, already his basal body temperature is more, or her basal body temperature is more. So do you think is she going to be comfortable in warm environment? No, already she is having more warmth in her body, more heat in her body. So where she would like to sit? In a cold temperature. So she is having heat intolerance. Heat intolerance. If you look at her skin, okay, so because of that heat in the body, there is excessive sweating. Excessive sweating. Okay, there's going to be excessive sweating, sir. So, like the palms and soles, when you look at the palms and soles, they are going to be sweaty. Okay, they are not dry, moist. Okay, moist palms and soles can be seen, sir. Excessive sweating is going to be seen. Now, what about their weight? What do you think about their weight? There's going to be weight loss or weight gain? So, there's going to be weight loss because more basal metabolic rate, more calories are getting utilized, more energy will be broken down, more ATP are getting utilized. So, there will be weight loss. Next, what about their heart rate? So, normally, generally speaking, thyroid hormones increase the heart rate. But hyperthyroidism, more T3, T4, more heart rate, there will be tachycardia. There will be tachycardia. So, sinus tachycardia is going to be seen. So, even during sleep, sir, normally when we go to the sleep, what happened to the heart rate? Heart rate decreases. But in these fellows, even during sleep, the heart rate is going to be high. This is called a sleeping tachycardia. Sleeping tach. Okay, sleeping tachycardia are resting tachycardia. Sleeping tachycardia, resting tachycardia. This is the most reliable sign. The most reliable sign of hyperthyroidism. Most of the students will think it's a proptosis, it's a bulging of the eyes, okay, as a most reliable sign. No, sir. That proptosis, that thing is going to be seen in Graves' disease only, not in other hyperthyroid conditions, not in others. It's going to be seen in Graves again and again, I'm telling you. Okay, don't think that every hyperthyroid female that's going to show up in your clinic is going to have the proptosis. No, it's going to be seen in Graves females. Okay. I am specifically saying Graves females is because Graves is most commonly seen in females. Autoimmune disorders are most commonly seen in females, sir, when compared to the males. So tachycardia is going to be seen. Next, thyroid hormones normally increases the GIT motility. More thyroid hormones, more hyperthyroidism, more GIT motility will be seen. So that will cause diarrhea. So that diarrhea is going to be seen. Next, thyroid hormones normally will make you active, keep you alert. Okay, thyroid hormones most like a sympathogenic hormones, they will make you alert. Now in hyperthyroidism, what is it for? What about the alertness? Going to be very much. Just not normal alertness. The female or the male is going to be so much anxious, anxiety. Okay, worried about everything. Actually, when you deal with these hyperthyroid patients, just by talking with them, you can have a preliminary diagnosis. This fellow is having hyperthyroidism, because they'll be doing they will be over talkative. So over talkative. If you ask one thing, they will be giving so much answers. Over talkative, anxious. Okay, so they are highly alert, anxious, over talkative. Okay. So because of this excessive amount of thyroid hormones, do you think they will sleep because of this anxiety? No, they won't even sleep, sir. So there will be insomnia. Okay, the patients are going to be insomniac. Okay, insomniac, not going to sleep properly. Okay, next, last. So especially in females, okay, that female who is having this hyperthyroidism can have menstrual irregularities. Menstrual irregularities can be seen. Which type of menstrual irregularity? That is oligomenorrhea. Oligomenorrhea. What exactly is oligomenorrhea? Irregular menses. Okay. Irregular menses. The exact reason why exactly this oligomenorrhea is occurring, we don't know. Normally menses should come. A female have to get this menses once in every 27 days. That's a normal cycles, 27-day cycles. But this female is going to get menses once in 2 months. Okay, once in 50 days. Irregular menses. So hyperthyroidism females can get irregular menses too. So all these other clinical features, what are they? Look here. Increased basal body temperature, basal metabolic rate increases, heat intolerance, excessive sweating, weight loss, tachycardia, diarrhea, anxiety, insomnia, and oligomenorrhea. Okay, oligomenorrhea. So these are some important points. Now look here. So what exactly is this? See, she is having proptosis. Okay, she is having proptosis, sir. Seen in which disease? Graves. Okay. Now in Graves, especially in Graves disease, not in other hyperthyroidism conditions, especially in Graves disease, these LATs antibodies are there, right? LATs. All credits for the LATs antibodies. Here also LATs. This LATs antibody is responsible for this proptosis. LATs antibody stimulating the fibroblast, more deposition of the collagen leading to the proptosis, and more deposition of the glycosaminoglycans, proptosis. Here also, we exactly don't know the reason why. So these LATs antibodies, again they will stimulate the fibroblast in the shin region, okay, the shins. So there is excessive deposition of substance called as glycosaminoglycans, GAGs, glycosaminoglycan deposition. The glycosaminoglycans, what they will do? They will attract the water. Wherever this glycosaminoglycan is there, they will start to attract the water, sir. So this is causing, okay, edema. This is not just a normal edema. This is mixed edema because of this glycosaminoglycans. So these glycosaminoglycans is like proteinaceous things. They will attract the water. So this is not just a normal edema. Normal edema means just fluid accumulation. This is glycosaminoglycans are there and even water is there. That it is osmotically pulling the water. So there is going to be pretibial mixed edema. Because why I'm telling you is, see, most of the students will think that myxedema is something seen. Okay, myxedema is something seen in hypothyroidism. Usually student mindset will be, sir, myxedema, I have studied that, myxedema coma, that's seen in hypothyroidism. But myxedema can also be seen in hyperthyroidism. Especially if they use this word, pretibial myxedema, 100% answer is Graves' disease. You can simply go and mark the Graves' disease. Pretibial myxedema, proptosis, these two features are something special for the Graves' disease. Okay, now tell me, so this pretibial myxedema is because of deposition of glycosaminoglycans, stimulating the, LATs antibody stimulating the fibroblast. Simple. Okay, so after this, what else? So here, this is the image-based question which was asked in the exam. That's why I am keeping it here. See, now this patient is having hyperthyroidism, sir, because of goiter. Okay, because of goiter. Now, you cannot see any goiter over here. Sometimes what happens is that thyroid enlargement is occurring but behind the sternum. This is called as a retrosternal goiter. Okay, for outside, the thyroid gland is not growing, but thyroid gland is growing back to the sternum. Okay, it's enlarging but back to the sternum, sir. So this is called as retrosternal goiter. How to identify retrosternal goiter? Retrosternal goiter. How to identify retrosternal goiter is, see, normally this is our thoracic inlet, right? Thoracic inlet. Okay. If you have a goiter in the thoracic inlet, okay, see, when I ask this patient to raise his hands up, to raise his hands completely up, okay, so what happens, as he is raising his hands up, the thoracic inlet, the size of the thoracic inlet decreases. In a normal person, that's okay, but this person is having a goiter, he's having a goiter in the thoracic inlet. So this goiter is going to compress the surrounding blood vessels. Okay, it's going to compress the surrounding blood vessels, jugular veins. So what happens? What happens is there will be flushing. There will be flushing in the place. There will be plethora. Look at here. The patient is having full plethora, red color. There is flushing. So the sign is called as Pemberton sign. Okay, the sign which I am showing here is called as Pemberton sign. So Pemberton sign is used, or it's seen, Pemberton sign, it is seen in patient who is having retrosternal goiter. Okay. Now, after this, what else I should teach you? Now, imagine there is one patient who is having Graves' disease, diffuse enlargement of the thyroid gland. He came to my clinic. Okay, he came to my clinic. Now, I am looking, there is enlargement of the thyroid gland. What I will suspect? Maybe this is a cancer. There is a possibility that there is thyroid neoplasia. It can be a thyroid neoplasia cancer, or it may be a benign tumor. So what I will do, I will ask this patient to go for a biopsy. Okay, let's have a clarity. Let's take a small biopsy, put it under the microscope, and let's see whether it's a tumor or it's a non-benign condition. Let's see whether it's a Graves' disease. So this is the Graves' disease, right? Graves' disease. So in Graves' disease, do you know what are the histological appearances that are going to be seen? If you look here in Graves' disease, these are the thyroid follicles. See how the thyroid follicles are. They are expanding. The thyroid follicles, they are not round and neat. They're expanding. That's okay. That's okay. But important point is at the edges of the colloid. Please appreciate at the edges of the colloid. How there is a loss of colloid. There is a loss of colloid material. Okay, there is a loss of colloid material in the edges, in the periphery. Okay, so this is called as scalloping of the colloid. Okay, let me write here. What is this appearance called as? This is called as scalloping of the colloid. Scalloping of colloid. So scalloping of the colloid is histological feature of Graves' disease. That's it. Normal colloid should be something like this. Okay, let me show you. See this is how good the colloid is. Okay, how good the colloid is. But in this condition, of course, a little bit amount of scalloping is okay. But in Graves' disease, there is too much. Look, there is too much amount of scalloping that's going to occur. Okay, so scalloping of the colloid, it is seen in Graves' disease. Okay, and next, what else, sir? What else? See, when you look here on fine needle aspiration, not on biopsy. This is not seen on biopsy. If you do FNAC, fine needle aspiration cytology, you have put a small needle and you have taken some tissue. Okay, aspiration, fine needle aspiration cytology. On fine needle aspiration cytology, you can see this appearance, flame kind of appearance. Okay, flame kind of appearance. So this is called as fire flames, right? Fire flames, fire flames. Now this was a question asked. So fire flames are seen in which study? Biopsy? No, FNAC. So why these fire flames? So these fire flames, what exactly are these fire flames? So these are nothing but rough endoplasmic reticulum. Okay, more T3 T4 need to be produced, right? More T3 T4 need to be produced. So more thyroglobulin need to be produced. T3 T4, they are made up of which protein? Thyroglobulin. So these fire flames are because of endoplasmic reticulum. They are because of rough endoplasmic reticulum. Okay, the rough endoplasmic reticulum is appearing as that fire flames. Okay, so these are some important points which I want you to know regarding hyperthyroidism. Hyperthyroidism ho gaya. Histological features I have explained, fire flames and scalloping of the colloid. Now after this, let me explain you about hypothyroidism, sir, quickly. Okay, let me write hypothyroidism. Hypothyroidism. What are the causes of hypothyroidism? Let me tell you here itself. What are the causes? What are the causes of hypothyroidism? The causes of hypothyroidism is, okay, as a Shehzad. Okay, everyone, yeah, please follow. Hypothyroidism. What are the causes of hypothyroidism? One, Hashimoto's, thyroiditis. I will explain what exactly is Hashimoto's thyroiditis and what you should know regarding Hashimoto's thyroiditis. I will explain you. Hashimoto's thyroiditis. Second cause is iodine deficiency. Okay, iodine deficiency. So Hashimoto's thyroiditis and iodine deficiency is going to cause hypothyroidism. Hypo. Okay, hypothyroidism means what? T3, T4 are not there. T3, T4 are not there. So whenever the T3, T4 are not there, now exact opposite clinical features are already you know it. So now tell me what happened to the basal metabolic rate. The basal metabolic rate decreases. Basal metabolic rate decreases. So when the basal metabolic rate is going down, what happened to the body temperature also? The activity, the the reactions in the body are going down, sir. Okay, the basal metabolic rate is going down. As the metabolism is less, what happened to the body temperature? The body temperature also will be less. Okay, there is less amount of body temperature. Less basal body temperature is going to be low. So as their basal body temperature is low, if you touch their extremities, are they going to be warm or cold? They are going to have cold extremities. Okay, if they are having cold extremities, now this patient who is suffering with, imagine this patient who is suffering with hypothyroidism, she came to my clinic. Now I am in my clinic. Okay, I am in my OP. Now there is an AC, sir. There is air conditioner everywhere. Now this patient who is having hypothyroidism, now she came for the consultation. Now is she going to feel comfortable in the AC room? No, already her basal body temperature is less. She is having cold extremities, the cold, her body is cold. So what happens? There is cold intolerance. Cold intolerance is going to be seen. If I examine her body, okay, if I examine her body, if I look at her palms and soles, sir, going to be cold, okay, but is she having sweating? No, she is not having sweating. The basal metabolic rate is less. She is having cold extremities. Already her extremities are cold. So in cold environment, do you have sweating? No. So she is going to have dry, scaly skin. She is going to have dry, scaly skin, sir. Okay. Now what about her weight? No metabolism. So weight gain. So weight gain. Okay. She will say, sir, I'm not even eating anything. These days I'm eating very less, normal food only. But still I am putting on weight. Weight gain is going to be seen. Why? Because there is no metabolism. Thyroid hormones are not there. Metabolism will be less. Thyroid hormone increases the basal metabolic rate. Okay. So weight gain is going to be seen. If you look at her heart rate, there will be bradycardia. Okay. Bradycardia is going to be seen. So next, if you look at her, the GI problems, the thyroid hormones are responsible for the GI motility. Now in this condition, no thyroid hormones. So GI motility is going to be less. So less GI motility, no proper GI contractions. That's going to cause what? Constipation. Okay, constipation. She is going to suffer with the constipation. Next, if you look at her mood, okay, if you look at her mood, she is not going to be active, sir. Always, like the thyroid hormones activate the central nervous system. Now here, thyroid hormones are not there, so she is going to be always dull, depressed. Okay, so she is going to have depressed mood. So that's why most of the patients, like most of the females who is having hypothyroidism, they will be depressed, calm, depressed, always sleeping. Okay, always they will try to sleep. Okay, so depressed, sleeping mood. Now, menstrual irregularities. If I talk about the menstrual irregularities, sir, she is also going to have menstrual irregularities, but mainly which problems, sir? She is going to have excessive bleeding. Okay, excessive bleeding. That is called as menorrhagia. Okay, why exactly is it happening? We don't know. But that female who is going to have hypothyroidism is going to have severe bleeding, sir, excessive bleeding. Okay, menorrhagia. Excessive bleeding means more than 80 ml blood loss. Normally in that 5 days of menses, a female have to lose somewhere around 50, usually 30 to 50 ml blood loss will be seen. If there is more than 80 ml blood loss, it's considered as menorrhagia, excessive blood loss, excessive bleeding, menorrhagia, sir. And next, other important points. See, this female who is having, okay, this female who is having hypothyroidism, okay, hypothyroidism. What else you should know is that in this female, there will be mixed edema. Okay. See, if you see the word pretibial mixed edema, the answer is Graves' disease. Don't even mark the hyperthyroidism, mark Graves' disease. Graves will cause hyperthyroidism, okay, Graves' disease. Now here, sir, in these patients what happens is, mixed edema is going to be seen. Okay, in hypothyroidism, look, normally under our skin, okay, the older proteins are going to be there, right? Older proteins. See, the older proteins need to be properly degraded. Thyroid hormone function is, thyroid hormone is a catabolic hormone. Okay, catabolic hormone. Thyroid hormone causes the proteolysis, breakdown of the older proteins, older collagen, older proteins. Okay. Now, if I am having hypothyroidism, the older proteins are not properly cleared, not properly removed. So, there is accumulation of the older proteins under my skin. Also, the glycosaminoglycans, the glycosaminoglycan breakdown needs the thyroid hormones. So, because of the accumulation of these older proteins, proteins are osmotically active. They will absorb the water. So, there will be mixed edema. Proteins are going to be there. And water is also getting accumulated. So, there is a mixed edema, proteins and water. So, it's not a normal pitting edema, sir. This is not a normal pitting edema. Only if you have water, there is going to be pitting edema. Now, this mixed edema is a non-pitting edema. Okay, it's a non-pitting edema, sir. Okay, why? Simple. Thyroid hormones are not there. No degradation of the older proteins. Fluid absorption. That fluid is going to be accumulated in the tissues, leading to mixed edema. What is that mix? Proteins are there. Mixed edema, non-pitting edema. Now, next. So, what is the most reliable sign of hyperthyroidism? The most reliable sign of hyperthyroidism is resting tachycardia. Okay, resting tachycardia or sleeping tachycardia. But in hypothyroidism, remember this one important MCQ, it is hung up ankle jerk. Okay, hung up ankle jerk. So normally in hypothyroidism, whenever you try to do for the reflexes, the reflexes are going to be less. Okay, all the reflexes, there will be hyporeflexia, sir. I should say there will be hyporeflexia. Hyporeflexia, all the reflexes are going to be less. Hyporeflexia, not a proper reflexes. But there is this one important thing which is very important for your exam. Whenever you see this word, okay, whenever you see this word, hung up ankle jerk, 100% the answer is hypothyroidism. Sir, what is this hung up ankle jerk? Look here. Now, the Achilles tendon, when you are tapping on the Achilles tendon, there should be a jerk something like this. Jerk, okay, jerk something like this. But in a person who is having hypothyroidism, so whenever you tap on the Achilles tendon, the foot is going to go like this and it will slowly come back. It will slowly come back, sir. Flexion, slowly it is going to come back. Okay. So this is called as hung up ankle jerk. Hung up ankle jerk is the most reliable sign of hypothyroidism. Exactly why it is happening, we don't know. Okay, because many books mentions like the patient is having excessive glycosaminoglycans. They are not being degraded. These glycosaminoglycans will go and deposit in all this, the reflex pathways. That hyporeflexia will be seen. There is no proper explanation, sir. But one thing what I can tell you is that in hypothyroidism there will be hung up ankle jerk. All reflexes are going to be less. Okay, these are the clinical features. Once see, less BMR, less body temperature, cold extremities, cold intolerance, dry scaly skin, weight gain, bradycardia is going to be seen, constipation, depression, depressed moods, always sleeping, okay, excessive bleeding during the menses, mixed edema is going to be seen, all reflexes are going to be less, all reflexes are going to be less. Okay. Now here I want to add one more important thing, okay, actually I forgot to mention one more thing, sir, which is needed for your exam. Look here, how many types of hyperthyroidism do you know? How many types of hyperthyroidism do you know? There are two types of hyperthyroidism, sir, primary and secondary. Let me write here. Hypo also. Hypothyroidism. Hypothyroidism. How many types? Two types. One is primary and secondary. Primary and secondary. Sir, what is the difference between primary and secondary? You know it. Primary means some problem in the thyroid gland. Some problem in the thyroid gland. Can I tell you example? Hashimoto's. Hashimoto's. Okay, Hashimoto's thyroiditis. Sir, what exactly is this Hashimoto's? See, in Hashimoto's thyroiditis, now I am telling you, just remember, for now, just remember, see, Hashimoto's thyroiditis, the thyroid gland is getting damaged. How it is getting damaged? In thyroiditis topic, I will explain you. Just for now, remember, thyroid gland, gone. Thyroid gland is gone, sir. Okay, so the thyroid gland is gone. So when thyroid gland is gone, what happened to T3, T4 levels? T3, sir, decreases, T4, sir, decreases. T3, T4 levels are less. Only it's the thyroid which is damaged, but hypothalamus pituitary are normal. So what happened to TSH levels? They will produce more amount of TSH, sir. Because thyroid gland is gone, no T3, T4, whenever the T3, T4 are not there, there is no negative feedback. No negative feedback is not there. As there is no negative feedback, more amount of TSH. Okay, the brain and pituitary gland are thinking, array, there is no T3, T4. Okay, let me produce more amount of TSH so that TSH will go and stimulate the thyroid gland, so more T3, T4 will be produced. But damn, here the thyroid gland is gone. Okay, so in primary hypothyroidism, look, the T3, T4 levels are less, but the TSH levels are more. In secondary, see, in secondary hypothyroidism, problem where? Problem at the level of pituitary gland, maybe damage to pituitary gland, gone, sir, damaged, or hypothalamic damage, hypothalamus pituitary glands are damaged. So when the pituitary gland is damaged, necrosis, the entire pituitary gland is necrosis, sir, seen in Sheehan syndrome, right? Sheehan syndrome. Okay, I don't want to go into that detail. Pituitary gland gone. When pituitary gland is gone, what happened to the TSH levels? The TSH levels are less. As there is no thyroid stimulating hormone, see, the thyroid stimulating hormone is not coming. So what happened to the T3, T4 levels? T3, T4 are not getting produced. T3, T4 levels are also less. So one thing is common, sir. Okay, it doesn't matter whether it is a primary hypothyroidism or secondary hypothyroidism, the T3, T4 levels are always less. But what is the difference? The difference here, in primary, TSH levels will be more. In secondary, the TSH levels is going to be less. Okay, so based on the TSH, will differentiate, sir. Now here, many students, will have this one confusion. Look, I'm talking mainly about primary. Okay, clinical feature, primary hypothyroidism. Primary hypothyroidism. What is the example? Hashimoto thyroiditis, sir. Now tell me, primary hypothyroidism, right? So what is this? This is hypothalamus, TK. What exactly is this? This is anterior pituitary, okay. What is this? This is a thyroid gland. Now, thyroid gland is damaged. Thyroid gland gone. Okay, concept. So, what happens to the hypothalamus? So, there is no negative feedback. T4 is not there, T3 is not there. So, there is no negative feedback, sir. So, what happened to the TRH levels? Sir, TRH levels are going to be super high. Now, more TRH is going to be released from the hypothalamus. So, this TRH, it will come. Yes, it acts on the thyrotropes. Okay, it acts on the thyrotropes. Now, this is the thyrotrope. So, what happened to TSH levels? So, TSH levels will be more. Okay. But important point is that this high levels of TRH can even stimulate one more type of cells, sir, which are called as lactotropes. These high levels of TRH can stimulate the lactotropes. Now these lactotropes, they will produce prolactin. So because of this prolactin, the female is going to have milk production. So it's not just the baby which can make the mother to lactate. It's the hypothyroidism also. If a female is going to have a primary hypothyroidism, not secondary, primary important. If a female, if she is having primary hypothyroidism, then also she is going to lactate. Is this normal milk production? No. This is galactorrhea, sir. This is galactorrhea. So a female with the primary hypothyroidism is going to have galactorrhea. Okay, galactorrhea. So done, sir? Done? Completed? Now, what else I should teach you? What else I should teach you? Here, look. Imagine there is a severe hypothyroidism. Okay, first let me explain you the concept. Later, let me come back to the thing. Very important for your exam. Even the recent exams has asked this question. The complication. Complication of hypothyroidism. A complication of hypothyroidism. One complication, let me tell you. Okay, let me tell you one complication. The thyroid hormones T3, T4 are responsible for brain development. Okay, they are responsible for what? Brain development during embryogenesis, for the brain development. Also, they are responsible for skeletal development, okay, brain development, skeletal development. Now, okay, thyroid hormones, they are very much important for the brain development during, like, embryo stage and even after the birth. Sir, even after the birth, thyroid hormones are very much important during childhood. Okay, thyroid hormones are very much important for the brain development and skeletal development during childhood. Now, imagine there is this one child who is having congenital hypothyroidism, which means because of some reason in his body the thyroid hormone production is very less, because maybe he is living in an iodine deficiency area or he is having Hashimoto's thyroiditis. Okay, because of some reasons, there are some other conditions like syndrome like let me tell you what is this transporter. Exactly, I'm not getting it, but there are many syndromes. Okay, I will tell you in the topic. There are many syndromes in which hypothyroidism can be seen. So if a baby is having hypothyroidism, okay, now what happens? Tell me. Do you think brain development is going to be there? No. Do you think skeletal development is going to be there? No. So the baby is going to have MR, mental retardation, along with dwarfism. Okay, yeah, that syndrome I said, Pendred syndrome. Okay, Pendred syndrome. There is a syndrome called as a Pendred syndrome. In this Pendred syndrome, also, if the baby is having Pendred syndrome, then also congenital hypothyroidism by birth, thyroid hormones are not producing. So whenever the thyroid hormones are not there, so brain development is not going to occur. So the patient is going to be mentally retarded and the patient is going to have dwarfism. So what this child is suffering with? So this child is suffering with a condition called as cretinism. Okay. Okay, the child is suffering with a condition called as cretinism. What exactly is cretinism? Cretinism is a child who is having mental retardation and dwarfism due to congenital hypothyroidism. These babies are called as cretins, cretin babies. Okay, so this is one complication of hypothyroidism, sir. Okay, second complication. The second complication is severe complication. This is the severe complication which is called as mixed edema coma. Okay, which is called as the mixed edema coma. So what exactly is mixed edema coma? What exactly is mixed edema coma? Say now the patient is having severe hypothyroidism. Severe hypothyroidism. So the severe hypothyroidism is there. What happened to the basal body temperature? The thyroid hormones are very much important for the maintenance of the body temperature. Now in severe hypothyroidism, there is going to be hypothermia, sir. Okay, so body temperature is going very, very less. Severe hypothyroidism, body temperature is going very, very less. What about the basal metabolic rate? The basal metabolic rate is also going to go down. The basal metabolic rate is going down. All the enzymatic reactions, okay, all those enzymatic reactions which are needed to keep the body in homeostasis are going down. Metabolism is going down. Body temperature is going down. Enzymes stop functioning. So when the enzymes stop functioning, what happens, sir? So these patients will go into coma, sir. Okay. Patients will land up in coma, sir. So this is called as mixed edema coma. Okay, mixed edema coma, you can say something like severe hypothermia, severe, like, the basal metabolism is going to go down. Enzymes stop functioning. When the enzymes stop functioning, ATP production goes down. Simply the patient is going into the coma. Severe complication, mixed edema coma. Okay. Now tell me, sir, if a patient is presented to you, your clinic with mixed edema coma, so what you are going to treat? The treatment, sir. What's the treatment that you are going to do? Treatment is, you have to give these patients, okay, active form. Normally for hypothyroidism, look here. Let me show you. So this is hypothyroidism, right? Hypo. Sir, for hypothyroidism, what is the treatment done? The treatment done is levothyroxine. Levothyroxine. What is that? T4. Levothyroxine, T4. If you give T4, the T4 will in the body T4 will be converted to T3. It does its function. For normal hypothyroidism, the treatment is levothyroxine tablets, old white, same tablets. But in this condition, in this complicated condition, okay, in this severe condition, emergency condition, what is the treatment? Mixed edema coma. You are going to give T4? No. You are going to first give, initial treatment will be done with T3. The active form, sir, emergency, you have to give the active form. So that is leothyronin. So leothyronin, okay, is the initial drug given. But if they ask you what is the drug of choice, drug of choice is T4 only, sir. That is thyroxine. Okay, so drug of choice for mixed edema coma is always thyroxine. But initial treatment should be done with leothyronin T3. Okay, so completed. Hypothyroidism is also completed. The mixed edema coma is also completed. Mixed edema coma is seen as a complication of hypothyroidism. What are the causes of hypothyroidism? Cause of hypothyroidism can be Hashimoto's thyroiditis. Where is this? Hashimoto's thyroiditis or iodine deficiency. Hashimoto's thyroiditis is most common cause of hypothyroidism in West. Iodine deficiency is the most common cause of hypothyroidism in India. Okay, in India, sir. Done. Now after this, let's begin with the topic of thyroiditis. Okay, let me add here. So, right, thyroiditis. Now, one thing, guys, remember, thyroiditis, thyroid gland, itis, inflammation. So in thyroiditis, let me, in the topic next 15 minutes, I will be explaining you different types of thyroiditis. Okay. One point is the thyroiditis, decurrence thyroiditis, renal thyroiditis, postpartum thyroiditis. Okay. So this thyroiditis, are they going to cause hyperthyroidism or hypothyroidism? Remember one point, all of them are going to cause hypo. Okay, thyroiditis are going to cause hypothyroidism. Okay, so hypothyroid means T3, T4 production is going to be less. Hypothyroid. Okay, so now let's begin with the first type of thyroiditis, that is Hashimoto's. Look here, this is Hashimoto's thyroiditis. What is the problem in Hashimoto's thyroiditis? Okay, what is the problem in Hashimoto's thyroiditis? So you can very clearly see, first before telling you problem here, first conditions, Hashimoto's thyroiditis. Is it a painful condition or painless condition? Yeah, all of the thyroiditis are usually painless, sir. All of the thyroiditis are painless. This is also painless. Okay, one exception is there. I will tell you what is that. So there is painless. Again, diffuse enlargement of thyroid gland. Painless diffuse enlargement of thyroid glands. Painless diffuse enlargement of the thyroid gland. This is the most common cause of thyroiditis in the Western world. I have just explained you. It's the most common cause of hypothyroidism. Hypothyroidism. It's the most common cause of hypothyroidism in West. Okay, in the Western world, the Western hemisphere, it's the most common cause. Now, can you guys anyone Tell me, what's the other name for Hashimoto's thyroiditis? Hashimoto's thyroiditis. It's also called as lymphocytic thyroiditis. Okay, why? I will tell you. Why? Because it's the lymphocytes which will infiltrate the thyroid gland and cause the damage to the thyroid gland. So thyroid gland is done. Okay. So thyroid gland is having a problem. There is inflammation. It's a lymphocytic infiltration to the thyroid gland causing damage to the thyroid gland. Inflammation. So this is also called as lymphocytic thyroiditis. So where are normally lymphocytes supposed to be present, sir? Lymphocytes are supposed to be present where? So the lymphocytes are supposed to be present in lymph nodes, spleen. Lymphocytes are supposed to be present in the spleen, lymph nodes. Okay, B lymphocytes, T lymphocytes in the thymus. But in this condition, Hashimoto's thyroiditis, autoimmune condition, sir, where the lymphocytes, the lymphocytic cells, it will come into the thyroid gland. Now lymphocytes, what they will think is, this is my home. So lymphocytes will start to simply rest in the thyroid gland. They will simply grow in the thyroid gland. Okay, now in the thyroid gland they are causing the damage. So that's why if you look at the histology, sir, what you can see here, the germinal centers. See, this kind of appearance is a basic thing, right? This kind of appearance is seen where? So this is appearance. These are the germinal center formation. So the germinal center formation is seen in the lymph nodes normally. But so this is thyroid gland. How, if you ask me how I can say this is a thyroid gland, sir, dekho, these are the follicles. These are the follicles. Now what is happening to the follicles, sir? See, the number of follicles are decreasing. See, there is more infiltration of the lymphocytes. There's infiltration at the blue color dots. What are these? These are all the lymphocytes. Okay, so now what you can see here is histology is going to show, look here, lymphoid follicles. Condition is Hashimoto's thyroiditis. Okay, Hashimoto's thyroiditis. Okay, here also same. This is the image, normal image. Okay, they're showing. So you can see this germinal centers. Okay, these are the germinal centers. Lymphoid aggregate, the lymphocytes are forming the germinal centers. Okay, lymphoid follicles forming the germinal center. So right, one by one, histology. What is seen? Lymphoid cells aggregate. And what they are forming? They are forming germinal centers. If you see this one thing, enough. Germinal center formation in the thyroid gland, Hashimoto's thyroiditis, painless thyroiditis, diffuse enlargement of the thyroid gland. Okay, it's an autoimmune condition where thyroid gland is getting damaged. Now, here, if you look at the follicular cells, so these follicular cells, okay, now let me show you. See, the follicular cells are going to show the prominent oxyphilia. Okay, the pink color cell. Okay, so these cells, these follicular epithelial cells, now they are called as Hürthle cells. Okay, Hürthle cells, the abundant eosinophilic cytoplasm, pink color cytoplasm, with a prominent round nucleus. Okay, with a prominent single round nucleus in the center, with good amount of cytoplasm, pink color cytoplasm. So these are called as what? Hürthle cells. So very important in histology. Graves, in histology graves, what you have seen? Scalloping of the colloid, fiery flames. But here, in this condition, right, what you will say is Hürthle cells. Hürthle cells. These Hürthle cells are also called as oncocytic. Oncocytic cells, also called as Ashkenazi cells. Okay. So Hürthle cells, oncocytic cells are Ashkenazi cells, all are same. Now, Ashkenazi cells are seen in Hashimoto's thyroiditis, Hürthle cells are seen in histology, Hashimoto's thyroiditis. So this is a painful condition or painless condition? Painless condition, sir. Painless condition. Now, after this, what else I should teach you? See, dekho. Sir, it is associated with what? Sir, this Hashimoto's thyroiditis is associated with any genetic associations. MCQ, very important MCQ. So genetic association, right? Genetic association. Histology I have explained you. Hürthle cells, Ashkenazi cells, and lymphoid aggregate, the germinal centers are seen. Genetic association is HLA-DR3. HLA-DR3, sir. Okay, associated with HLA-DR3 and HLA-DR5. Okay, HLA-DR3 mutations, HLA-DR5 mutations can lead to this Hashimoto's thyroiditis. Okay, so that's the one thing. HLA-DR3, DR5, very important, especially for the board exams outside the India. HLA-DR3, HLA-DR5 association is seen with Hashimoto's thyroiditis. Now, in this condition, some important antibodies are also seen in the blood. In the blood, sir, in the blood, you will see some important antibodies. In Graves also we have seen antibodies, right? Which antibodies? LATS antibodies, long-acting thyroid stimulating receptor antibodies, TSH receptor antibodies are seen. Here also see antibodies in blood. Which type of antibodies are seen? Very important, TPO antibodies. Anti-TPO means anti-thyroid peroxidase. Thyroid peroxidase is an enzyme. Anti-thyroid peroxidase antibodies. Okay. Next, anti-thyroglobulin antibody. Thyroglobulin is a protein. Thyroglobulin is a protein which is involved in the formation of T3D4. So anti-TPO antibodies, anti-thyroglobulin antibodies, and also anti-microsomal antibodies. So all these are important, especially for the board exams outside India. In Indian exams, this is very important, sir. Anti-thyroglobulin antibodies are seen in. Okay, anti-microsomal antibodies, anti-TPO antibodies are seen in which condition? Hashimoto's thyroiditis. What exactly is Hashimoto's thyroiditis? Autoimmune disease. Antibodies are attacking? No, it's not the antibodies. It's the lymphocytes. Okay, it's the lymphocytic aggregates. The lymphocytes which will come into the thyroid gland and forms the germinal centers, causes the inflammation, damage to the thyroid gland. Okay, now let me tell you one more important point here itself. Imagine there is this one fellow, sir, who is having Hashimoto's thyroiditis. There is a female, usually it will come in females. There is this one female who is having Hashimoto's thyroiditis. Sir, imagine first of all, this is a normal thyroid gland. Look here, this is a normal thyroid gland. Okay, now she is having Hashimoto's. Okay, now she is having Hashimoto thyroiditis. Now, first normal thyroid gland, sir. Now it is getting inflamed because of this lymphocytes, lymphocytic aggregates. So, the thyroid gland is getting damaged or not? Yes, thyroid gland is getting damaged. As the thyroid gland is getting damaged, what happened to the T3T4 which is already there in the thyroid gland? See, in the thyroid gland, we have enough T3T4 for the next 3-4 months. If you come and damage my thyroid gland right now, all the T3T4 which is needed for the next 3 months will be spilled into the blood. There is spillage. So that will cause what? Initially in Hashimoto's, initially there will be hyperthyroidism features. There will be features of hyperthyroidism. But what happens? So the T3T4 will be used within the 1 month, will be used. All this T3T4, whatever is leaked, it will be used, and the thyroid gland is damaged. So this hyperthyroidism, it follows with hypo. Okay, it follows with hypo, sir. So initially hyper, followed by hypothyroidism. Initially hyper, followed by burnout phase. Burnout means entire thyroid gland is damaged. So initially hyper, followed by hypothyroidism. That's the one point which I want you to know. I have discussed about the antibodies also. Next, what else? Sir, if you are having Hashimoto thyroiditis. Okay, Hashimoto thyroiditis. Sir, is there any problem in the future? Okay, your thyroid gland is damaged. Okay, let the thyroid gland damage. Okay, let it damage, sir. Let it damage. We can replace the thyroid hormones from outside. From outside, we can use the thyroid hormones. But is there any problem in the future with this thyroid gland, Hashimoto's thyroid gland? There is a damage. Do you know what is that? Cancer. So these patients with the Hashimoto's thyroiditis, they are at risk of papillary carcinoma of thyroid gland. Papillary carcinoma of thyroid gland. Okay, papillary carcinoma of the thyroid gland. And in the thyroid gland, who is coming and sitting? Now the thyroid gland is behaving like a lymph node. Lots and lots of lymphocytes are coming and staying there. So there is a risk of lymphoma. Okay, so lymphoma, sir. So Hashimoto's thyroiditis increases the risk of papillary carcinoma of the thyroid gland as well as lymphoma. The first type of thyroiditis completed. Now the second type of thyroiditis which I want you to know is this seen in the lady. See, now she's a lady. She had a baby. Now she's having pain, sir. Okay, she's having some problem with the thyroid gland. So do you know what is this condition called as? So this is called as postpartum thyroiditis, also called as AKA subacute, okay, subacute lymphocytic, okay, subacute lymphocytic thyroiditis. The only reason why I am discussing this here is, sir, you know lymphocytic thyroiditis. What is lymphocytic thyroiditis? Lymphocytic thyroiditis is Hashimoto's thyroiditis, painless enlargement of the thyroid gland. Okay, but if they use the word subacute lymphocytic thyroiditis, subacute condition, actually this condition is not a problematic, sir. So this is going to be self-resolving. Okay, it's going to be self-resolving condition, not a severe condition. Without even treatment, it will self-resolve. Okay, so that is subacute lymphocytic thyroiditis is postpartum in nature. It's a postpartum thyroiditis, but generally normal lymphocytic thyroiditis is Hashimoto's. Hashimoto. Okay, many exams I have seen this question. Okay, I don't know why, but they will ask you. Subacute lymphocytic thyroiditis seen after pregnancy, females. Okay, after delivering the baby. Self-resolving condition. No need to do anything. Next, sir. After this, the next type of thyroiditis that I am going to discuss here is Dickwer-Weins. Okay, Dickwer-Weins thyroiditis. How I used to remember, sir? Dickwer-Wein, painful. So normally thyroiditis, I have said you, it's a painless condition. It's a painless condition. But which type of thyroiditis is having severe pain in the thyroid? Always put the diagnosis Dickwer-Weins. Painful, vein pain. Okay, vein pain. So Dickwer-Weins thyroiditis, it's also called as subacute granulomatous, not lymphocytic. Subacute granulomatous thyroiditis. So in the name itself is there. So granuloma formation in the thyroid gland. Granuloma formation. Pain is, yes, there. Why? What's the problem? Why the problem started, sir? Viral. After viral infection, okay, post-viral infection, you have got some viral infection, respiratory tract infection, flu. After this viral infection, you have developed the thyroiditis. They will say, after the viral infection, the patient have severe pain in the thyroid gland. What might be the reason? Dickwer-Weins thyroiditis. Okay, post-viral thyroiditis is Dickwer-Weins thyroiditis. What's seen in the histology? The one important point which I want you to know is in histology, sir, it's a granulomatous thyroiditis with the multinucleated giant cells. Okay, you can very clearly see here. So these are the granulomas. These are the granulomas with giant cells. Okay, these are the granulomas with the giant cells. So one thing you can very clearly say, sir, these are the thyroid follicles with the granulomas also. Okay, thyroid follicles, the granulomas. That is post-viral thyroiditis, Dickwer-Weins, completed. Enough. 1 point, enough. Next, Dickwer-Weins, after Dickwer-Weins, one more important point is there. This is not that important. But let me tell you. See, all thyroiditis presents with hypothyroidism. One thing you know, all thyroiditis presents with hypothyroidism. Yes, even Dickwer-Weins also. But Dickwer-Weins mainly in the initial phases, when you are having inflammation, initially it presents as hyperthyroidism. Not because of production, sir, not because of T3, T4 production. It's the gland damage, the damage to the thyroid gland, leaking more T3, T4, just like Hashimoto's. Okay. So, Graves, see, dekho, Graves disease, hyperthyroidism. Even in Dickwer-Weins, what I am trying to put into your mind is that it predominantly presents, okay, it predominantly presents as hyperthyroidism initially, later becomes hypothyroid, okay. But how to differentiate? Now, look at this condition, guys, very important for your exam. Let me put here. Let me put important points here. Differential diagnosis, DDX, between Graves and this condition, that is Dickwer-Weins. Dickwer-Weins. You can also say Dickwer-Weins or Hashimoto's. Dickwer-Weins or Hashimoto's. Sir. How to differentiate? Sir, in Graves, tell me, there is more activity of the thyroid gland, more T3, T4 production. So what happened to the REIU study? Radioactive iodine uptake study is going to be more radioactive iodine uptake. More radioactive iodine will be uptaken into the thyroid gland. In Dickwer-Weins, tell me, sir, is there more activity in the thyroid gland? No, thyroid gland is getting damaged. That's why hyperthyroidism features. Okay, so here radioactive iodine uptake will be less. So how to differentiate between Graves and Dickwer-Weins or Graves and Hashimoto's based on the radioactive iodine uptake study? Okay, that's the one point which I want you to know, sir. Next, look at here. What is happening? So this is the thyroid gland. How can you say this is the thyroid gland, sir? Dekho, here all these are the follicles. Okay, all these are the thyroid follicles. Now, in the thyroid gland, are you able to appreciate what is this? This is the scarring, sir. There is a scarring or fibrosis. Okay, scarring or fibrosis. What is this condition? So, this is Riedel's thyroiditis. Okay, where there is excessive fibrosis, fibrosing thyroiditis, sir. Riedel's. Okay, Riedel's. Right? Let me write the important points here. Already it was given. Let me just highlight the important points for you. Riedel's is also called as fibrosing thyroiditis. There is fibrosis of the thyroid gland. So, it is usually associated with IgG4 related disorders. Okay, IgG4 is an antibody. See, now, can you tell me what is this image? The Dupuytren's contracture. See, simple. If you are having some fibrosing disorder in your body, okay, fibrosing disorders, for example, like, see, retroperitoneal fibrosis. Retroperitoneal fibrosis. Dupuytren's contracture due to excessive fibrosis of the tendons. Okay, excessive fibrosis. So, this Riedel's thyroiditis is also associated, it's a fibrosing disorder, sir. Everywhere in the body, excessive fibrosis is happening. Okay, excessive fibrosis is happening. Look here. So, these are the IgG4 related disorders. Okay, IgG4 related disorders. They usually cause fibrosis. This IgG4 antibody, it's going to cause the fibrosis. For example, like Mucklid syndrome, fibrosis of salivary gland and lacrimal gland. Kuttner tumor, fibrosis of submandibular glands. Riedel's thyroiditis, just now we have discussed. It's an example of IgG4 related spectrum of the disorders. Okay, see, eosinophilic angiocentric fibrosis, retroperitoneal fibrosis, also called as Ormond's disease. What I'm trying to put into your mind is simple. IgG4 antibody related diseases will have fibrosis in the body. Different places, different fibrosis. Even thyroid gland is also undergoing fibrosis. Okay, so how the thyroid gland is going to look like? Soft or hard? Woody hard, sir. As hard as a wood. As hard as a wood. Okay, so patient, let me show you. The patient is going to have, see, painless thyroiditis. Yep, thyroiditis is there. Inflammation will be there, followed by fibrosis. Painless. Every condition is painless. But Dickwer vein, pain. Dickwer vein is painful. Post-viral, painful. Okay, so thyroid gland in this condition, that is a Riedel's, it will become as hard as a wood, sir. As hard as a wood. Thyroid gland is here. Back to the thyroid gland, what is there? Larynx. Larynx, simple larynx, thyroid gland. Back to the thyroid gland, trachea, larynx is there. So this fibrosis will extend even to the larynx, sir. So fibrosis of the larynx will cause problem during breathing. So the patient can have stridor or dyspnea. So fibrosis extends into the surrounding structures, especially this is important for the board exams. Fibrosis extends to the surrounding structures, so the patient may experience symptoms like stridor and dyspnea. Associated with other fibrosing disorders in the body like retroperitoneal fibrosis, okay, and Dupuytren's contracture. Important point is, sir, this condition, Riedel's thyroiditis, how the thyroid gland, it's hard as a wood, it's hard as a wood. Thyroid gland is hard as a wood, sir. Okay, now it mimics what? It looks like anaplastic carcinoma. Okay, there is a cancer, thyroid gland cancer called as anaplastic carcinoma. Even in this cancer, anaplastic carcinoma, the thyroid gland is going to be very hard. We'll call it as a stony hard thyroid. Stony hard. Now in this condition also, the thyroid gland is like woody hard. So Riedel's thyroiditis, it looks like anaplastic carcinoma. Because in both the conditions, thyroid gland is hard. Fine needle aspiration is not possible. Hard thyroid. Okay. So Riedel's thyroiditis is also completed. Now after this, the last topic for today, it is tumors. Tumors of the thyroid gland. Tumors. Okay. Now let's complete it as fast as possible, as simple as possible. Let's not to skip anything. All important points, let's complete some. So benign tumors. The first benign means not a cancer. First benign tumor is called as follicular adenoma. Follicular cells are there, you know, right? Follicular cells are there. Follicular cells are there. They are getting a tumor, sir. They are getting a tumor. Follicular adenoma. Okay. So this is follicular adenoma. See, this is normal follicles. These are the normal colloids. These are the normal colloids. Okay. So this is the tumor, sir. This is the tumor. Important point about this follicular adenoma is it's going to have, dekho, what is there? It's a well circumscribed, a capsule is there, a proper capsule is there. The same thing, let me show you in the histology also. Look here, in the histology also, sir, this is the tumor. Here are the follicles present, the normal follicles present here. Now, the tumor is surrounded by a well demarcated capsule. There is a well capsulated thing. It's a well capsulated tumor, follicular adenoma. Now, question is, the follicular adenoma, why the hell there is a follicular adenoma, sir? Okay, follicular adenoma, why? So, this follicular adenoma is because of a mutation called as RAS mutation. Okay, there is RAS mutation. RAS gene mutation gone, sir. RAS gene mutation. Important point is there is any follicular damage? Sorry, capsular invasion is there. Capsule is invaded because of this tumor cells? No. So, capsule invasion, right? Capsular invasion negative, sir. Capsular invasion is negative. Okay. So, this follicular adenoma, is it going to produce excessive T3, T4? Do you think? No, sir. No. No T3, T4 production. No T3, T4 production. It's not going to produce excessive T3, T4. It's just a tumor. It's just a tumor, sir. A tumor in the thyroid gland. Simple tumor, well capsulated tumor. So, you will be having a goiter, maybe. You will be having a mass. But no hyperthyroid features. No, very important, no hyperthyroid features. Follicular adenoma, RAS mutation. Very important MCQ. Okay. Next. Look here. This is also follicular adenoma, sir. Okay, forget about this Hurtl cell. Okay, just write follicular. Okay, sir, of course there is a like Hurtl cell adenoma, but not that important. See, imagine this is a follicular adenoma. Look what is happening here. Sir, if the capsule, once if it is invaded, damaged, so can you call it as follicular adenoma or follicular carcinoma of thyroid gland? It's called as a follicular carcinoma. Once the capsule is invaded, capsular invasion positive. Now we are not going to call it as follicular adenoma, follicular carcinoma. Okay, follicular carcinoma, sir. Okay. So these are the important differences between follicular adenoma and follicular carcinoma. What is the difference? Same, RAS gene mutations only. In both the conditions, RAS gene mutations only. If the capsule is well preserved, it is follicular adenoma. If the capsule is invaded, it is called as follicular carcinoma. Done. Next, after this, let me talk you. Let me tell you one more thing. One more benign tumor, sir. Right? Next benign tumor. The next benign tumor that I am going to discuss here is called as toxic adenoma. A toxic adenoma, not follicular adenoma, not just follicular adenoma. It's a toxic adenoma, sir. Sir, what is the problem? What are the problems with the toxic adenomas? In the name itself, it is a toxic. Why toxic? So these toxic adenomas are going to produce T3, T4s. Excessive amount of T3, T4 production is going to be seen. So this T3, T4, what they will cause? Hyperthyroidism. Hyperthyroidism. Features of hyperthyroidism. My question is, sir, follicular adenoma is because of RAS gene mutation. But toxic adenomas are because of which gene mutation, sir? GNAS mutation. GNAS mutation. EZH1 gene mutation. Important. So mutation of these genes. Okay, GNAS. One of the most important is this, sir. GNAS. Okay, I used to remember something like this. Toxic means not good. Bad. Toxic means something problematic. So I used to remember something like this. So whenever you are having a gas explosion, gas cylinders will be there, right? Gas cylinders, explosion. Hyperthyroidism kind of thing. See, sir, I used to remember something like gas cylinders, explosion. Why explosion? Because hyperthyroidism, in this condition, this tumor is producing excessive amount of T3, T4. So toxic. So gas leakage is something toxic. Okay, like an explosion, like something like, okay. So you can remember it anyway, in whatever the way you want. So benign tumors, two benign tumors that I have discussed, follicular adenoma as well as toxic adenoma. Follicular adenoma, no T3, T4. Toxic adenoma, T3, T4 production is going to be there. Follicular adenoma, RAS gene mutation. This toxic adenoma, it is a GNAS, okay, GNAS mutation and EZH1 gene mutation. Okay, cancer. Next, let's directly jump into thyroid neoplasias. Neoplasias means what? Cancers. Now not benign, cancers are cancer. Okay, so how many types of thyroid neoplasias are there? 4 types. Papillary carcinoma, follicular carcinoma, medullary carcinoma, anaplastic carcinoma, and the least variety is also there, that is lymphoma. Lymphoma cell. Where we have discussed which condition can lead to lymphoma in the thyroid gland? Lymphocytic infiltration seen in Hashimoto's thyroiditis germinal centers. Okay, so papillary carcinoma, follicular, medullary carcinoma of thyroid gland, anaplastic, and lymphoma. Okay, lymphoma, sir. Okay, so what is the least or rare varieties? Rare, sir. Rare are anaplastic and lymphoma. They are rare. They are the rare, sir. Now, one important point about the medullary carcinoma here itself I am telling you. Sir, if you are having a thyroid gland, if you are having a thyroid gland, sir, in the thyroid gland, what kind of cells are there? Follicular cells will be there. And there are parafollicular cells also. So, if you have cancer, if you are having a cancer to the parafollicular cells, cancer of parafollicular cells. The cancer of parafollicular cells, which is called as medullary carcinoma. So, this medullary carcinoma, it's a cancer of parafollicular cells. The cancer of parafollicular cells is called as medullary carcinoma. Okay, medullary carcinoma, sir. Okay, okay. So, let's write one by one. I have explained important points: papillary, follicular, medullary, anaplastic, and lymphoma. Okay, let me tell you one more important point here itself. Sir, out of all these cancers, which cancer do you think is having good prognosis and bad prognosis? That's also an MCQ. The worst prognosis, anaplastic carcinoma is having worst prognosis. Then who is having best prognosis or excellent prognosis? Papillary. Going to have best prognosis. Okay, so papillary carcinoma is going to have good prognosis. Anaplastic carcinoma is going to have the worst prognosis. So, without any further late, let's begin the papillary carcinoma. The first type, the most common, sir, most common. Why? Because of RAS gene mutation? No. Because of GNAS mutation? No. It is because of BRAF V600E gene mutation. BRAF V600E gene mutation is going to cause thyroid neoplasia associated with what's a radiation exposure previously for the treatment of acne or for the treatment of some esophageal disorder or esophageal cancer. Imagine that there is patient having esophageal cancer. Now he is taking radiation therapy. So now this radiation is going to fall on the thyroid gland. Thyroid gland can get into the cancer. Which type of cancer? Papillary cancer, carcinoma of thyroid gland. For acne, for the treatment of acne, you are taking the radiation treatment. This radiation is going to fall on the thyroid gland, forms the cancer. So, radiation exposure is going to cause papillary carcinoma of thyroid gland. Boards, especially for the board exams, this is very, very important. Radiation exposure. Okay, or thyroglossal cysts. Presence of this thyroglossal cyst, you will study that in surgery, in your surgery topic, thyroglossal cyst. Okay, Hashimoto's thyroiditis we have discussed. Hashimoto's thyroiditis. Hashimoto's increases the risk of papillary carcinoma. Okay, for you. Okay, let me just show you 1 second. It will take. See, Hashimoto's increases the risk of papillary carcinoma as well as lymphoma. The risk factor. True. So, what are the risk factors? Previous radiation exposure. Okay, previous radiation exposure, thyroglossal cysts, and Hashimoto's thyroiditis. Okay. Now, what are seen on the histology, sir? Histology. If you look at the histology, very, very important MCQ for board exams and Indian exams. See, if you look at the histology, you can see this papilla, right? Okay, you can see this papillary projections. Okay, papillary projections, sir. That's why papillary carcinoma. You can see the papilla. Okay, so that's why the name papillary carcinoma. But if you look at the cells, sir, how the nucleuses are looking like? They are like clear, sir, clear. Okay, it's looking like this character. Okay, this cartoon character which is called as Orphan Annie. Now, this is a character, cartoon character, it's serial. Okay, so how her eyes are looking like? There is no iris. It's completely white. Okay, only sclera is there, completely white. So here, the tumor cells are also looking like this. The nucleus is looking like this, clear. Okay, so that's why orphan Annie-eyed nuclei. Where orphan Annie-eyed nuclei are going to be seen? Papillary carcinoma. Orphan Annie-eyed nuclei are going to be seen in papillary carcinoma. Okay, I have explained you the papillary carcinoma is going to have the best prognosis. And also here in histology, you can see the samoma bodies. You can see the samoma bodies. Sir, what are the samoma bodies if you ask me? So here also very clearly see, dekho, orphan Annie-eyed nucleus, the clear nuclei are going to be seen, the clear, okay, clear nuclei. So what are the samoma bodies? Samoma bodies means, see the tumor cells, imagine, okay, the tumor cells in the cancer, that's a cancer, right? Now in this cancer, the tumor cells, the calcium will come and deposit, sir. The calcium will love to come and deposit in the cancer. Now there is a cancer. Now in that cancerous area, the calcium will come and start to deposit. cancer. There is destruction of the tissues going on. Calcium will start to come and deposits. So there are these whorls of calcium deposition or the lamellated appearance because of the calcium deposition. So these are called as, see, dekho, papillary thyroid carcinoma, where you can see the psammoma bodies. What exactly are the psammoma bodies? They are concentric layers of calcium deposition in the tumor. The concentric layer of the calcium deposition in the tumor. So these are the psammoma bodies. So what are the histological features that are seen, sir? Histological features that are seen are orphananiaid nucleus, papillae can be seen, next psammoma bodies can be seen, and if you look at these cells carefully, okay, if you look at these cells carefully, then look here, how this nuclei is looking like, it's looking like a coffee bean, right? It's looking like a coffee bean. Here also, how this nucleus is looking like, because of some inclusions, because of some intranuclear inclusion, it is looking like a coffee bean. So these are called as coffee bean nuclei. Okay, there is presence of MCQ, very important MCQ, intranuclear inclusions are positive. Intranuclear inclusions are positive. Because of this intranuclear inclusions, what kind of nuclear appearance is seen? So coffee bean nuclei. Coffee bean nuclei is going to be. So what are the histological appearance? Coffee bean nuclei. Some other bodies can be seen. Orphananiaid nuclei. Okay, and papillae. Okay, you can see the papillae, sir. Papillary projections. Papillae are going to be seen. Done. So after this, what else I should teach you? Some of what is, you know it. Now the next type of thyroid cancer that I am going to discuss here is called as follicular carcinoma, sir. Follicular carcinoma. Have you ever heard about follicular adenoma? Follicular adenoma, toxic adenoma, benign tumors, just don't forget. Okay, look here. Dekho guys, here we have discussed about follicular adenoma. Follicular adenoma. Now in follicular adenoma, there is a proper capsule that is present. It's a well capsulated, there is a proper capsule. But what if the capsule is damaged? If the capsule is infiltrated, then it is called as follicular carcinoma. That's what I'm going to discuss now. Okay, follicular carcinoma. That's right. So, yeah. So follicular carcinoma. Now tell me, sir, in follicular carcinoma, what is the gene mutation? Follicular adenoma, what is the gene mutation? RAS gene mutation is the same gene mutation. So RAS gene mutation is positive. What I have said? Capsular invasive, invasion. Capsular invasion present. Capsular invasion is present. Okay, capsular invasion is present. Look here. So these are the tumor cells. Okay, these are the tumor cells. Now, look here, this is a capsule. Here is a well circumscribed capsule is there. Okay, there is a capsule. Okay, now they go. The capsule is invaded. So the capsule is broken. Now the tumor cells are invading the capsule. Okay, capsular invasion is seen. Okay, so that's the important point. Capsular invasion is going to be positive, sir. Now, other important point is, sir, it's a carcinoma, right? Follicular carcinoma. So usually carcinomas are spread by lymphatic route. Okay, usually carcinomas, they will spread by lymphatic route. But this is something special, sir. Follicular carcinoma. So follicular carcinoma, it will go via the blood. Via the blood vessels. So one exception, very important. Usually carcinomas, they will spread by lymphatic route. But this one, follicular carcinoma, it spreads by very, very important hematogenous route. Hematogenous route. Spreads by what? Which route? Hematogenous route. So, RAS gene mutation, capsular invasion is present, spreads by hematogenous route. But all carcinomas, usually all the carcinomas in the body, they spread by lymphatic route, but this spreads by hematogenous route. So that's why, okay, see, follicular thyroid carcinoma. See, what are these? These are the blood vessels. Tumors will go into the blood vessels. Tumor cells will go into the blood vessels. Okay, see, vascular invasion. The blood vessels are going to be invaded. So hematogenous spread. Okay, hematogenous spread is going to be seen. That is the important point which I want you to know. So this is also completed. Follicular carcinoma is also completed. First one is Papillary carcinoma, orphan aniide nucleus. Second one is follicular carcinoma, RAS gene mutation. Next type of carcinoma that I want you to know is medullary carcinoma. Okay, medullary carcinoma of thyroid gland. Already I have explained you that medullary carcinoma is a cancer of which cells? Parafollicular cells. Okay, medullary carcinoma, it is a cancer of, it's a tumor of C cells or parafollicular cells. Why? Red gene mutation, red oncogene mutation, red oncogene mutation. It is associated with what? Sir, it is associated with MEN2 syndrome. So there is a syndrome called as multiple endocrine neoplasia type 2. In these patients who are having multiple endocrine neoplasias, the name itself is there, multiple endocrine cancers. The body multiple endocrine cancers are there. One such cancer is this medullary carcinoma of thyroid gland. See, for example, let me tell you, sir, in men too, the patients are going to have pheochromocytomas. The patients are going to have medullary carcinoma of thyroid gland. The patients are going to have other tumors like, like mucosal, neuromas, okay, something like that. So, this one, MCT, medullary carcinoma of thyroid gland. It is seen with MEN2 type syndromes, multiple endocrine neoplasia type 2. Okay, both in type A and type 2A and 2B. Multiple endocrine neoplasias are further divided into 2A and 2B. Both in 2A and 2B, it is seen. MC, multiple medullary carcinoma of thyroid. Okay. So, now tell me, it's a cancer of which cells? It's a cancer of parafollicular cells. It's a cancer of parafollicular cells, right? As it's a cancer of parafollicular cells, it will produce which substance? Sir, imagine there is this one fellow who is having medullary carcinoma of thyroid gland. Now this fellow is producing what? Is producing excessive amount of calcitonin. Okay, so that's why in this condition the tumor marker is calcitonin. Calcitonin. Now imagine there is this one person who is having a medullary carcinoma of thyroid gland. Now you have taken the biopsy. Now you are putting under the microscope. Okay, you are keeping it under the microscope. There is a slide, you have prepared the slide and you are seeing it under the microscope. What you will be seeing? Sir, you will be seeing the parafollicular C cells. Okay, these are the tumor cells. The parafollicular cells are C cells. In between these tumor cells, what else can be seen, sir? So this patient, again and again I am telling you, so this patient is having what? Cancer of parafollicular cells. So these parafollicular cells, what they will produce, sir? So these parafollicular cells are going to produce calcitonin. Sir, what is calcitonin? It's a peptide hormone. Calcitonin is a peptide hormone. So, in this tumor, everywhere you will see this calcitonin. Everywhere you can see the calcitonin, sir. This is the calcitonin. Okay, hormone, calcitonin. Everywhere you can see this pink color protein. So, now what you are seeing? So, the tumor cells are seen in the background of amyloid. Why I am calling it as amyloid? Amyloid means abnormal protein deposition. What is this abnormal protein, sir? This is nothing but. So this is nothing but our this is nothing but our calcitonin. So this calcitonin, it is previously long back, the scientists thought that this is amyloid, sir, some amyloid pink color material, but this is nothing but calcitonin. Okay, calcitonin. This is amyloid. So if wherever you have, listen this word, okay, this one thing, sir, the tumor cells, the patient is having some goiter or like an enlargement of the thyroid gland, you have taken the biopsy, and in the biopsy it is shown that the tumor cells are seen in amyloid background. Which type of cancer? Medullary carcinoma of thyroid gland. See, remember, first cancer that we have discussed, papillary carcinoma, okay, BRAF V600E gene mutation. Second one, follicular carcinoma, RAS mutation. The third cancer, medullary carcinoma, it is red oncogene mutation. First one, orphan aniide nucleus, the papillary carcinoma, orphan aniide nucleus, coffee bean nucleus, some of our bodies. The second one, follicular carcinoma, important point is hematogenous spread. The third one, medullary carcinoma of thyroid gland, carcinoma of parafollicular C cell. Calcitonin, excessive amount of calcitonin will be there. So, tumor cells are seen in amyloid background, red gene mutation. In these patients, I am asking you generally, tell me, so there is more calcitonin, right? As there is more calcitonin, what happened to his calcium levels? Hypocalcemia, sir. There is hypocalcemia, less amount of calcium in the blood, hypocalcemia. So, which type of thyroid neoplasia is associated with the hypocalcemia? Medullary carcinoma of thyroid gland. And the, look here. So, what is this? All this pink color material, whatever you are seeing here, all this pink color material is amyloid. Okay, all this pink color material is amyloid. All these are the cancerous cells. Okay, all these cells are the cancerous cells. And the pink color, whatever I have highlighted here, this is amyloid. Okay, the explanation was given here. They go, the amyloid deposition in medullary thyroid carcinoma. Okay, see, you can stain it, sir, actually. Okay, when you do staining, look here. So, you know, right? The amyloid is going to stain with Congo red. Amyloid is going to stain with Congo red, sir. See, when you stain with Congo red, it is giving pink color appearance, salmon pink amyloid on light microscopy. So, what is the stain used for amyloid? The stain used for amyloid is Congo red. Okay, here also given, see, see, there is amyloid stains bright orange or red color with Congo red. Okay, but if you put it under the polarized light, what it will show, sir? It will show apple green birefringence. Amyloid under light microscopy, it will show like this. Okay, that salmon pink color appearance or orange or red color appearance, amyloid. But if you put it under the polarized light, see, it is showing this green color, apple green birefringence. Okay, so this is called as apple green birefringence, which is shown by the amyloids. Okay, because in medullary carcinoma of the thyroid gland, it's the amyloid deposition, calcitonin, peptide hormone, abnormal protein deposition, sir. Okay, so medullary carcinoma, Congo red stain you have done. After Congo red stain, you have kept it under the polarized light. What it is showing? It is showing apple green birefringence. Okay, and the last type of cancer which I want you to know is, okay, the last type of cancer, sir, which I want you to know is anaplastic carcinoma. Before going to the anaplastic carcinoma, I want to add one more integration here. One integration, sir. Which people are at a risk of medullary carcinoma of the thyroid gland? Which people? See, there are drugs called as incretins. Okay, incretins, sir. Incretins. See, these are the diabetic medications. Incretins are the diabetic medications. Okay. See, these incretins, the patients who are using incretins, they are at increase, especially for the board exams. This is important. Incretins increases the risk of MCT, medullary carcinoma of thyroid gland. Incretins increase the risk of medullary carcinoma of thyroid gland. Okay. Incretins are the medications used for the treatment of diabetes mellitus. One integration I wanted to know, enough. So, last type of thyroid cancer, that is the anaplastic carcinoma. Only one point. So, this anaplastic carcinoma, it's the most dangerous. It's having worst prognosis. Most dangerous, worst prognosis. Best prognosis is papillary carcinoma. This is having worst prognosis. Now, in this condition, anaplastic carcinoma, if you look at the thyroid gland is going to be stony hard. Stony hard thyroid, sir. Okay, it's very hard again. So, it's mimicking what? It mimics what? Which condition? Two conditions are going to look similar. Riedl's. Riedl's thyroiditis. In Riedl's thyroiditis also woody hard thyroid gland, it mimics anaplastic carcinoma. Both the conditions, thyroid is going to be hard. Okay. So worst prognosis, anaplastic, good prognosis, best prognosis, papillary. So with this, thyroid neoplasias are also completed. So all in one place, like most of the thyroid disorders, hyperthyroidism, hypothyroidism, thyroiditis, as well as thyroid neoplasias, important topics which you need to know for your exams are done. Hope the video is helpful. In tomorrow's class, let's continue with the parathyroid glands. Already it's late, it will be enough for today. Let's continue with the parathyroid glands in tomorrow's class. Hope the video is helpful. Thank you guys. See you tomorrow. Good night. Azzy, thank you. Good night.